Hi, everyone. I'm David Perez. I'm an associate professor of neurology and psychiatry at Harvard Medical School, also based out of the Massachusetts General Hospital. It's my pleasure to be here with all of you today to discuss the topic of the new diagnostic and treatment paradigm in functional neurologic disorder, which I'll abbreviate as FND. These are my disclosures. And I want to first begin to set the stage here for all of us to hear directly from a patient who's been generous in allowing us to record an event where she presented symptomatically and symptoms evolved and improved over the course of several minutes. I'd also like to highlight that this individual had FND with mixed symptoms, including what you'll see very clearly as a form of functional facial dystonia. But other events, including to some degree the one presented here, include an element of functional speech. And she has distinct events of functional limb weakness and functional seizures. At times, the functional dystonia precedes onset of her symptom complex, including functional limb weakness and functional seizures. So here's her symptom description.
Describe for me,
Yes.
what are you experiencing right now?
I think I'm emotional because my speech is off and my face is very hardly twisted.
And it was a rainy day in the city of Boston that day. And so here she gives us a bit more context.
And the guy says, "This happened before." He says, "I don't have the name, like I'm lying." Anyway, before that happened, I had another incident. I went into the wrong door, and the door was open on the side. And the security said to me, "How did you get in here? Like I'm like a criminal or something." I said, "Well, the door was open, and I came in. I had to get out of the wet because it was so pouring out." And I think that could have escalated the FNG episode because it stressed me out. And he says, "Oh no, go down this way," and it's okay because I think he saw maybe that I was upset.
And just a few minutes later.
FND now.
I think I'm a professional. I understand how it ticks. I wish I could get rid of it. That would be the greatest thing. But it's something I have to live with. So I have to have my tools to make this not so severe and come out of it faster. Before, I couldn't come out of it faster because I really didn't know what to do. And the first thing people say, "Oh, don't talk, because it's going to get you more excitable and more nervous and do it." Actually, that's the total opposite. Talking helps to tell people and to understand what FND is. And then the face starts to come back up and the face starts to relax.
So, our outline for this talk, I really want to highlight that as we bridge neurology, psychiatry, and rehabilitation specialties in F&D care, we can think about the neuropsychiatric approach to the assessment as really critical not only for diagnosis, but setting the stage for treatment. And we'll talk about a range of other treatment strategies, including education and a range of physical interventions, rehabilitative interventions, and skills-based psychotherapy, among others. So in setting the stage for treatment, right, we're talking about the assessment, plus communicating the diagnosis and engaging the patient around the diagnosis and the proximal next steps in treatment, right? With patient engagement being really critical as well. And let's begin this conversation also with a quote from Stanley Cobb, who was a neurologist and started the first department of psychiatry at the Massachusetts General Hospital where I work. And his quote, "There is no problem of mind versus body because biologically no such dichotomy can be made. The dichotomy is an artifact. There is no truth to it. And the discussion has no place in science in 1943. Really forward thinking. I would argue in 2024 and as we enter 2025, this has yet to be fully realized, but we're making a lot of progress. And maybe progress includes going back to the future with improvements. Let's also be clear on terminology. I'm using the term functional neurologic disorder, abbreviated FND. This is synonymous with the lengthier term found in the DSM-5, functional neurologic symptom disorder. It's also synonymous with conversion disorder. However, use of conversion disorder has really fallen out of favor. And it's fallen out of favor in part because it makes reference to a very specific mechanism that might be relevant for some patients, but is now thought to not be universally relevant for all. And the big paradigm shift that's happened over the past several decades is this is no longer a diagnosis of exclusion. Instead, this is a diagnosis of inclusion, a rule-in diagnosis, specifically wearing our neurologic expertise hat to appreciate robust rule-in signs on neuroexam that are specific for a functional neurologic disorder. And we'll go over a number of videos here today. There are a number of subtypes of functional neurological disorder. We're going to focus on functional movement disorder, also known as functional motor disorder. And this is inclusive of functional limb weakness. I also include in this category functional speech and voice presentations. Many patients have mixed symptoms, including that the urgent presentations of functional seizures, I think, require a fair amount of consideration as well, including with the focus on rehabilitation, not so much because physical rehabilitation interventions are core to its treatment, but it may be coexistent in other cases of a functional movement disorder. And we want to think about its triage. Other subtypes, functional dizziness, functional sensory deficits, functional cognitive disorder, are experiences between 1 in 5 to nearly half of patients have mixed presentations. Okay, very, very notable. But we'll focus here predominantly on functional movement presentations. This is not a rare problem. If you're working in neurologic care settings, in the emergency room, in the outpatient clinic, in the inpatient setting, in acute rehabilitation settings, you see this. The literature suggests that FND is likely a top 5 reason to be referred to an outpatient neurologist. Also, just very recently, is an authoritative systematic review on the incidence and prevalence of FND published in the JNNP led by Sarah Finkelstein. And just to highlight, so the incidence of FND here was estimated at 10 to 22 per 100,000, while the minimum prevalence of FND was estimated at 80 to 140 per 100,000. Not only is this common, but it's expensive. And the data suggests that when we look at healthcare expenditures in the emergency room and inpatient setting alone in the US, at least 1.2 billion is spent annually in healthcare costs for this patient population. That number, by the way, appears to only be rising in follow-up calculations currently under review by Christopher Stephen and colleagues. So the neuropsychiatric assessment, we want to confirm the diagnosis using a rule-in approach. But we also want to structure the assessment such that we can remain vigilant for neurological and medical comorbidities, and that we put the patient's diagnosis in context using the biopsychosocial formulation. Who is this given patient in front of me with a functional movement disorder, for example? And there is tremendous heterogeneity to that question. So the challenge here is that there isn't a simplistic formulaic approach that bridges the gap between diagnosis and treatment plan. The rule-in signs, so critical for diagnosis, but rule-in signs by themselves won't translate into a patient-centered treatment plan. And how to bridge that gap, I would argue, and many in the field argue, the approach is the biopsychosocial formulation. So let's think about this a bit more deeply, right? I am a neuropsychiatrist and deeply interested in brain behavior relationships. As such, I have a deep-seated interest in pathophysiology and mechanisms. And yet, I would contrast a singular focus on pathophysiology. We can think of this as biomedicine versus pathophysiology in context. That being the biopsychosocial model, right? With this notion that a singular focus on pathophysiology alone will fail to deliver precision medicine in a great number of cases. This was articulated brilliantly by George Engel, a medical internist, in his seminal article published in Science in the 1970s. Biological factors, psychological factors, sociocultural, spiritual factors. Across these domains, we can think about risk factors, acute precipitants, and perpetuating factors. The perpetuating factors, by the way, critically important for treatment planning. So our approach. This group of patients has frequently accessed the healthcare system in a number of ways, likely before they've gotten to your clinic, before they've entered your emergency room, before they've been admitted to your inpatient ward. A focus chart review, tremendously helpful, right? What kinds of symptoms are we dealing with in terms of the core presenting features? What physical symptoms and related diagnoses might be co-varying? Also, what workup has happened to date? And what emphasis on a rule-in diagnostic approach has happened to date? All of that super helpful to get a sense of from the chart review. But nonetheless, wherever you're meeting the patient, start with their chief complaint. Start with their neurologic symptoms, as you would with other cases. And here, as you meet Mr. or Mrs. Jones, right, and they may be presenting with functional limb weakness or limb weakness and walking trouble, right? So you want to get a sense of how this began, how it's evolved, what other symptoms might be accompanying or starting to occur in addition to their leg weakness and trouble walking. And as you gather that history, there might be some historical clues, right? Sudden onset in a short interval of time, right? I was walking 2 days ago entirely normally. Now I am incapacitated, unable to stand up from a chair, unable to take 1 or 2 steps independently, right? This tempo certainly can be the tempo of neurologic emergencies, which need to be thought about critically and thoughtfully. It's not the tempo, however, of many indolent, slowly progressive neurologic conditions, but it is the tempo of a functional neurological disorder as well. I've highlighted this notion of mixed symptoms. I just think it's worth noting, including pain, fatigue, cognitive difficulties. And what's critical about this is if you tailor your assessment entirely to focus on limb weakness, and walking trouble. And you might be quite thoughtful and appreciate rule-in signs and quite engaging with the patient. And yet, at the end, they might say, doctor, thank you for your opinion about these symptoms living in between neurology and psychiatry. I guess you're calling this a functional movement disorder. I think you all are missing something. I've had extreme fatigue. I hurt all over. Sometimes I can't even get the words out. I feel like you all are missing something. And to avoid that common pitfall, you need to think broadly. Start with the cheap complaint, but think about the full spectrum of co-occurring physical symptoms. Acute precipitants, why now? Yes, at times it can be an affectively charged event, but increasingly we recognize that it can also be a physically linked event. For example, concussion, mild TBI, peripheral limb injury, presentations post-surgery. And we can think mechanistically, it's not as though there's been a structural lesion or injury that's happened, but rather with physically latent precipitants. There's a tension drawn to the body. And it's a tension drawn to the body that is really very mechanistically important in this patient population. Also, having a diagnosis of FND with robust rule-in signs does not preclude that another medical or neurologic condition might be co-occurring as well. And just to be as clear as we can on this, for example, there's a literature to highlight that a subset of patients with Parkinson's disease also have a functional movement disorder. There's a literature on associations between MS and FND. And 1 in 5 patients with functional seizures has comorbid epileptic seizures. That means 80% of those with functional seizures have isolated functional seizures, but still a notable minority to keep in mind. Okay, now after you've taken a thoughtful dive with the patient around their physical symptoms, I and others argue that you want to think about taking 2 strategic detours. This is in part to put the patient's symptom complex in context, transitioning to the social history as well as a focused psychiatric screen. Part of it here is there's so much heterogeneity. So who is this patient in front of you with a given functional movement disorder? I find that signposting where you're going with the interview is really helpful. So for example, Mr. and Mrs. Jones, would it be okay if we switch topics for a little bit? I'd like to get to know you a bit more as a person. Tell me about a typical day or typical week for you. What's that like? How do you spend your time on the weekends? Who are your supports? Right? Great questions to focus on the here and now and to listen. You'll learn quite a bit, including that a number of individuals in this patient population can be quite socially isolated. And that needs to factor into your treatment planning. If opportunities and settings allow, I find that a similar open-ended framing to understand their developmental history and early life trajectory can really set the stage as well for understanding who is this patient in front of you, and also opens a segue into a focused psychiatric screen as well. Also, risk factors, really to emphasize. There's this notion that patients with functional neurological disorder have elevated rates of childhood abuse and childhood neglect, summarized as childhood maltreatment. And the literature highlights that there's about a 3 to 5-fold greater propensity for these experiences in patients with FND versus control groups. But there's a lot of heterogeneity here, including that there is a subset of patients with FND who do not endorse a trauma history. Really important to acknowledge and it may not be present in some patients. So this notion of searching for what's not being endorsed might be quite misguiding and might be quite off-putting to the patient. Keep this in mind. The other piece is now transitioning using signposting again to the psychiatric screen. Mr. or Mrs. Jones, would it be okay if we switch topics again for a few minutes? Help me understand, over the last couple of months, how have you been doing emotionally? Now, here, this framing of asking, how have you been doing emotionally? I like to highlight, over the course of my psychiatric training, no one ever taught me to ask a question this way. And yet I found that it begins the conversation in neutral, open-ended fashion. It doesn't lead with, have you been feeling depressed or have you been feeling anxious, right? That comes next. But asking an open-ended question allows the patient to say, I'm feeling awful. I'm having a really tough time. In fact, I'm quite depressed and anxious. Or it opens the opportunity for the patient to say, I'm doing the best I can. I'm super frustrated. I don't understand my symptoms. I don't understand why I can't walk and move my legs at times. But, things have generally been stressful for a long time. And more recently, I'm doing all right. Right? So a range of possibilities here. So keep in mind heterogeneity in the risk factors, heterogeneity in the magnitude and severity and burden of mental health comorbidities in this population. And yet you also want to understand what's been their access and engagement with mental health treatment, right? If you're going to potentially suggest a role for skills-based psychotherapy in their treatment of their functional neurologic symptoms, then you sort of need to get a sense of, have they ever done skills-based psychotherapy to begin with, right? And what was their experience of that? Okay. You want to round out the rest of your history of present illness and associated categories, past medical history, medications, allergies, family history, as you would with any other kind of intake. And now a disclaimer. Everything I've mentioned about the clinical history, while it may raise an index of suspicion for a functional neurological disorder, and that index of suspicion is important in putting FND on the differential diagnosis, right? That index of suspicion and those historical clues by themselves are non-specific. What is specific for the diagnosis are rule-in signs on examination. So let's go over these using a series of largely videos. But before I do that, let me articulate for you all the most well-studied rule-in sign for functional limb weakness, and that's the Hoover sign. Now, you see the patient seated in the chair, and let's imagine that they're weak in their left leg, okay? As the examiner, you ask them to extend their weak left leg or push down into the ground. And if they're experiencing weakness in hip extension, you might find that you can lift up their left leg as they attempt to push towards the ground. Okay. Keep your hand underneath that characterized weak left leg. Now draw their attention contralaterally and have them flex at the hip with their strong right leg. As they flex at the hip with their strong right leg and show full strength doing so, you might find that there's excellent downward push now with that previously weak left leg. In fact, so much excellent downward push that you can no longer lift up that left leg. That is what you call a robustly positive Hoover sign. You can do the same thing with hip abduction. If you test abduction, lateral push of the leg outward, you might find that unilaterally it's weak when there's an element of functional limb weakness in that leg. But if you test bilaterally, you're engaging a contralateral reflex, similar to what's engaged with the Hoover sign. And now engagement of that contralateral reflex shows that there is excellent abduction of both legs bilaterally. That again is now a positive hip abductor sign. Collapsing giveaway weakness. I don't have a slide on it, but collapsing giveaway weakness is this notion of being strong for a moment on confrontation testing before your strength gives out suddenly. Now, collapsing giveaway weakness is very common with significant pain in the limb. So if you appreciate collapsing giveaway weakness, first question to ask the patient is that painful? Right? You don't want to confuse functional limb weakness with collapsing giveaway weakness that is occurring in the setting of pain. When there's pain, I will typically ask the patient to see if they can push through the pain for 2 seconds. That encouragement to push through the pain may have the collapsing giveaway weakness resolve. And if the collapsing giveaway weakness resolves as they push through the pain, then that's pain-limited weakness, distinct from functional limb weakness. Keep that in mind. That's a common pitfall I see in terms of a bit of diagnostic misuse of the term FND. Okay, let's talk about hyperkinetic functional motor presentations, the most common being functional tremor. And here, this video is going to highlight distractibility and variability in the pattern of tremulous movements. So there's a postural tremor in the bilateral hands and arms. As the patient flexes and extends their right wrist, you notice that postural tremor on the left, it stops, it starts. The amplitude of that reemergent tremor is highly variable. These are features of variability and distractibility. Here's another example. A rest and postural tremor in the right hand. Now we're going to introduce a competing motor movement on the left and complete resolution of that rest tremor that was previously seen. Okay, really striking. Tremor entrainment, another rule-in sign for functional tremor. Tremulous movements, functional in nature, may present with a certain rhythm. And can you have the individual engage in paced volitional movements in a different body part, such as an unaffected other hand? And can you influence the rhythm of their tremor, have it increase in frequency and decrease in frequency by the rhythm of paced volitional movements performed elsewhere? When you can do so in striking fashion, that's robustly present tremor entrainment. So very quickly, those tremulous movements took on the same pattern as the finger tapping movements performed on the right. And here's a video showing features of variability, distractibility, and entrainment in an individual with a functional tremor.
E86, 79, 72.
So here, cognitive distraction does not appear to be influencing the frequency of the tremor, but finger tapping, slow and deliberate, seemed to stop the tremor for a period of time. Now with more emphatic tapping, there's time-locked movements. You have variability, distractibility, and entrainment. Finger mirroring can also, or ballistic movements, can introduce a pause in the frequency of those tremulous movements. Okay. Functional gait presentations. There's a really nice article by a number of movement disorder experts published in Neurology in 2020. It's video based, very high yield if you're seeing patients with functional gait in your practice. Just one or two examples here. This is an example of somebody who presents to clinic with significant knee buckling on attempted gait. And yet you'll also see features of motor inconsistency, being symptomatic in a certain motor setting and not being symptomatic in another motor setting where those symptoms should really carry over from one motor setting to the next. When there's loss of carryover in ways that are paradoxical, that highlights a feature of motor inconsistency. And you'll see that the lack of carryover in this case is dancing.
Okay. Take another step. Okay. Now, do first position, do round de jambe. Okay, can you do underdog?
What?
Underdog.
Can you dance on your own without your mom? It doesn't.
That's Mark Hallett's voice in the background for those who know of his work in the area.
That's harder.
How about the other foot?
And not only is there a lack of knee buckling with dancing, but also with hopping on one foot and the other. Really striking, robust features of motor inconsistency. Dragging monoplegic gait. The leg drags behind the individual as if an inanimate object, often externally rotated, and frequently, at least in my experience, coupled with other rule-in signs for functional limb weakness in that externally rotated dragging limb. Dragging monoplegic gait, a type of gait pattern highly specific for functional gait. There are forms of functional dystonia. The most robustly identified rule-in feature is seen in the upper portions of the slide, where individuals can present with fixed dystonic posturing, with plantar flexion and inversion of the foot. This can also be at times co-varying with toe curling, as seen in the middle image. And I began this talk by showing you a presentation of an individual with functional facial dystonia, at times mistaken for a facial droop. And you'll see this presentation of functional facial dystonia in individuals who present with functional symptoms that resemble grossly a stroke-like presentation, right? But when you examine them, it's not a facial droop. It's hyperactivation and hyperactivation of the facial musculature, including hyperactivation of the platysma, giving the gross appearance of a facial droop. But it's something rather different. People have also argued for an overlap between forms of functional dystonia, particularly fixed forms, and complex regional pain syndrome. If you want to read more about that, the JNMP article in 2018 is a great read. And functional tic-like presentations are not new, but they have been brought to the forefront over the past several years, particularly with the pandemic. We know, for example, that a range of neurogenic tics typically present in childhood. There's a gradual evolution of tic progression. Initially, tics are rather simple motor tics, throat clearing, eye blinking. There's a male predominance. And more complex tics occur with cases as they evolve over the natural history. But functional tic-like presentations, adolescent or early adulthood onset, without a premorbid history of tics. Onset was acute and florid in its presentation, right? A high degree of severity on symptom presentation. Tics being more complex with motor and at times vocal features. And here, rather than a male predominance, there was a female predominance that was characterized. Functional tic-like presentations. Something to keep in mind if your clinical practice sees patients with a range of tic presentations. I've mentioned that the spectrum of functional motor disorder includes functional movement disorder, hypokinetic and hyperkinetic. We can think of functional speech and voice as, largely motor variants as well. And the three predominant subtypes of functional speech being functional stutter, functional foreign accent syndrome, functional infantile speech. You can look for rule-in signs of prominent variability and distractibility in the severity and manifestation of an individual's new onset functional tremor. And here, if you've never heard a case of foreign accent syndrome, here is a native English speaker. And I'm hoping to play this audio here.
I'd like you to tell me about this speech problem that you have. When did it start and what has it been like?
I supposedly had a stroke either 2003, 2004. I stuttered for a while, and then all of a sudden, I don't know, I never been able to talk a rata. Lot of aya stuck in my brain now. Come out, no. I was embarrassed for a long time, because I used to manage about 300-400 people, I talk to them every day, and then this happened, embarrassed me, but I about to get used to happening, because people all the time ask me where I'm from, where you born? You're not born in the United States. I say,
So indeed, a native English speaker. You can notice in portions of the recording some variability to the type of accented speech the individual is manifesting. Functional seizures. There are also rule-in signs for functional seizures. These include, for example, a major motor event beginning with tight eye closure at seizure onset. As that motor event evolves, you might notice that rather than the movements being tonic-clonic, that they're asynchronous, herky-jerky, stopping and starting. Okay? And here is a patient being admitted to the epilepsy monitoring unit and having their major motor functional seizure captured on video EEG.
Good. Keep blowing. It's definitely going to come again. Applesauce.
Those bicycle movements at first may have you think about frontal lobe epilepsy, but now there's more tremulous movements in the legs. The bicycle movements return, but at a lower frequency and amplitude.
Lift your right leg up in the air. Lift your left arm up in the air.
This patient's EEG before, during, and after this event was negative for epileptiform activity, only showed muscle artifact and normal background rhythm. Some cautionary notes. I've alluded to this in how I've spoken about the rule-in signs, but just to make this as transparent and as clear as I can, right? You want to be cautious when rule-in signs are marginally positive, right? If you're asking yourself, well, maybe there was an element of variability and distractibility, or maybe there was a positive Hoover sign, right? That should really have you bring in a colleague, right? If you're not seeing the patient in a neurology care setting, might you consult, for example, with a neurologist with proficiency in making this diagnosis to get that second opinion. So be wary of marginally positive signs on exam. Keep an open mind in those settings. The other piece too is a robustly positive rule-in diagnosis of FND does not preclude another neurologic comorbidity. conditions such as Parkinson's disease, multiple sclerosis, epileptic seizures, well described, among others. Okay, but you've done your neuropsychiatric, biopsychosocial informed assessment. You've looked for those rule-in signs. You tried to put the patient's clinical history in context. Let's state for the purposes of this discussion that rule-in signs are robust. Red flags for a major neurologic comorbidity are absent. You're satisfied that the diagnostic workup is complete. Okay. Where do you go next? Now, here, patients who are experiencing FND are in disarray. They're having a really tough time, right? So the good news delivery that their brain MRI is normal, the good news that their EEG didn't show epileptic seizures, the good news that their EMG nerve conduction study was normal, or that any labs that you may have sent in their blood were unremarkable. Not good news, right? Doctor, what is happening? Why am I having a tough time walking? Why am I having a tough time moving my legs? So what you want to focus on is deliver the diagnosis just like you would other conditions. Focus on what is happening. Mr. or Mrs. Jones, based on your history, and very importantly, based on your exam, including, for example, where we noticed together at times your tremor in your right arm seemed to go away entirely when I had you engage in tasks with your left hand. That tells us that the kind of tremor that you're having is a functional tremor. It's a type of functional neurological disorder. This is common. This is real. And treatments are available. Have you ever heard about functional neurologic disorder and functional tremor in particular? Most patients haven't. And that's really where it's an opportunity to give a deeper dive into this condition by giving the patient a walkthrough on educational materials available on the website neurosymptoms.org. If you're seeing patients with FND, if you're curious to learn more and you've never been to the website neurosymptoms.org, it's the one thing I most recommend after you view this talk. Also, focus on the what of diagnosis. Focus on the what of diagnosis based on the rule-in signs. Patients will ask why, right? But the why varies patient to patient. And I find that at times, patients, particularly those who do well, they find out the why for themselves as they undergo the treatment recommendations, such as physical rehabilitation, frequently coupled with psychotherapy. Okay. So focus on the what, avoid the pitfall of over discussing the why. The why varies patient to patient. The why can frequently be discussed directly by the patient after they participate in the course of treatment that you'll discuss next. So after you've gone over some educational materials, after you've delivered the diagnosis, FND, a condition that lives in between neurology, psychiatry, and rehabilitation specialties, that their symptoms are real, that you do not think in any way, shape, or form that they're crazy or making things up. And yet, this is a condition that you recognize, that is surprisingly common despite its lack of discussion in social contexts, and that treatments are available. As you have this conversation, a couple things. Give the patient space to ask questions. Okay? If they look doubtful, if they look confused, acknowledge it. See if there's a way to readily address any concerns. And if it seems multifaceted, then you might need more time, including they might need more time to review the materials, to review some of the patient testimonials, to click on some of the videos available on neurosymptoms.org, and discuss treatment at a later visit. That being said, many patients are receptive to treatment as the next discussion. And they say, okay, I hear you. So functional tremor or functional limb weakness, symptoms in between neurology and psychiatry. Well, how do I get better from this? Right? And the patient saying that is signposting that they likely are appropriate for next step discussions. The patient who dissociates as you begin the conversation, the patient who has a functional seizure as you begin the conversation, clearly not ready for definitive treatment recommendations at that first encounter. The other thing is, apart from patient engagement and how receptive are they to the delivery and communication of the diagnosis, the other piece here is, what did you learn about their formulation that might require some incorporation into the treatment plan? Is this a patient with Parkinson's disease and a functional movement disorder who's overusing their Sinemet in the context of actually a well-controlled Parkinson's disease, but a Sinemet overuse syndrome in the context of the patient treating their functional movement disorder with Sinemet? That clearly requires contextualization. Is this somebody who's been in a wheelchair, non-ambulatory, maybe an electric wheelchair for 5 years? Are there elements of deconditioning or muscle wasting? Is this a case of fixed dystonia, where you're worried about the possibility of contractures? All of these latter cases, really, really important to bring in a physiatrist as a co-pilot very early on in the treatment planning. A range of other biological, psychological, and social factors to consider, including this notion that fear avoidance is one of the constructs that comes up here, where individuals will, for example, attempt a modest walk, but that modest walk led to full body shaking and quite a bit of whole body pain for several days. So now they've restricted their ambulatory task furthermore, and this happens iteratively. So addressing that sometimes symptoms get worse before they get better is important. Also addressing there aren't any quick fixes, right? That there are treatments available, but this is not something where you think a pill and an external agent is going to be the driver of treatment, but rather the patient plays a critical role in the treatment journey itself. That is really, really important to get the patient to wrap their heads around. Okay, so stages of initial FND treatment. We've talked about assessment. We've talked about communicating the diagnosis. We've highlighted the importance of patient engagement. Let's think a bit more about evidence-based initial treatment recommendations. And again, not only is the assessment setting the stage for treatment, but education is the beginnings of treatment as well. Likely in isolation, it's not definitive treatment for the majority of patients, but it's an important component of such. You can then think about 3 additional components. Physical treatments for physical symptoms. Roles for PT, OT, and speech and language. Roles for skills-based psychotherapy. The greatest evidence being that for cognitive behavioral therapy. But your formulation may have you deviate, such as, for example, is this an individual with prominent emotion dysregulation, poor distress tolerance, frequent dissociation, frequent self-injurious behavior, and chronic suicidality? Those borderline personality traits might make you think about DBT, dialectical behavioral therapy, much earlier in the treatment algorithm than it might for others. And then treating comorbidities, sleep trouble, migraine headaches, major depression, chronic pain. Now, there are consensus recommendations for physical therapists written by leading physical therapists with co-authors. The physical therapy consensus recommendation written by Glenn Nielsen. There are similar outputs for occupational therapy, as well as for functional speech and voice disorders, all listed here on the slide. And what's really important is that you're going to hear from other colleagues about the core components, but just a few highlights. The treatment principles are different than the kinds of treatment principles that you might use to help motor recovery in a patient post-stroke, or a patient with multiple sclerosis or spinal cord injury. Right here, there's a limited hands-on approach. There is a focus on use of distraction and dual task to allow normal movements to reemerge, among other principles. And so here, I'd like to show you a couple of videos of this notion of a dual task, which really is tackling this notion that there's biased attention processing towards the body. And that biased attention processing towards the body, among other constructs, is playing a role in hijacking normal movements and perpetuating the functional motor presentation. So you can introduce a competing motor task to draw their attention away from their body or away from their symptoms, allowing normal movements to re-emerge. Here's one such case of a functional gait, a video courtesy of Julie Maggio, our neurophysical therapist lead in the FND unit. So non-economical compensatory movements. Now Julie is starting to teach this person to tap their thigh as they attempt to walk down that red line. And a few sessions later, you instantly notice the gait speed is better.
Good, and then turn around and come on back towards me.
Notice this turn, smooth, fluid, narrow-based. Complete absence of the non-economical compensatory movements you saw previously. Here's another example. This individual also having a functional movement disorder. Some features of non-economical compensatory movements.
The ball.
Postural control seems poor.
But you know what was so funny? She kind of looked at me. She looked like
You get a sense of some stiffening in her legs.
why I gravitated toward her. Because I was like, oh, she looks like me.
Right? And here, we're introducing a dual task.
Right. Okay. You ready? Yep. Powerful legs.
As you watch, movements are much more fluid, postural control is improved. Balance seemingly better. Okay. Occupational therapy, there are consensus recommendations. I'll just put a small spotlight on this notion that there's an increasing literature on sensory processing difficulties in patients with FND. Bright lights, loud noises, body pain seem to trigger or worsen functional neurologic symptoms. Some of this work has been done by Jessica Ranford and colleagues, where you can see that sensory avoiding and sensory sensitivity at much higher rates than most people in both a discovery sample of 44 patients and in a more recent replication sample of 77 individuals. Borrowing from the sensory processing difficulty literature in other conditions, such as that found in mood, anxiety, PTSD disorder, as well as the literature in autism spectrum disorder, we know that sensory modulation interventions, such as developing a sensory diet with regularly scheduled sensory meals and as needed sensory snack interventions to allow an individual to maintain a just right sense of balance, right? Not too hyper aroused and triggered, or not too under aroused and disconnected, but somewhere in between. Some of these sensory interventions can be helpful in conditions that we know can be comorbid in patients with FND. And Jessica Ranford, Julie McLean, and colleagues are now looking to see if this is an intervention that is therapeutically helpful in patients with FND. Retrospectively, we have some data to show it might be, with the majority of patients showing some degree of improvement who undergo this occupational therapy intervention. But we really need to do more prospective controlled work in this area to understand and know more. Functional speech. For the purposes of time, I won't play these videos, these audio clips, but just to highlight that the same themes around motor retraining for limb use can be used with speech and language pathologists to have patients undergo speech retraining. And I direct those to the consensus recommendations by Jan Baker and colleagues who want to know more. Okay. So physical treatments for physical symptoms, skills-based psychotherapy, a couple more pearls here. For some of you, it may be quite a while since you've thought about cognitive behavioral therapy. You may vaguely remember that CBT involves looking at associations between emotions, thoughts, and behaviors. Well, cognitive behavioral therapy for FND, five-way association between symptoms, thoughts, behaviors, emotions, and life stuff. There are a number of workbooks operationalizing the skills-based psychotherapy approach, and more specifically the CBT approach for treatment of FND. This self-guided workbook, Overcoming Functional Neurologic Symptoms, a five-area approach based on the Sharp et al. Clinical trial in 2011 in neurology, is an excellent read and resource. It's also the workbook that's been used to develop our own outpatient skills-based psychotherapy treatment at the center I work at. And some of the centers that have developed specialized intensive outpatient or intensive inpatient treatments have also leveraged this workbook as well. So it's quite high yield. And you can get a sense of examining illness beliefs, behavior patterns such as boom and bust or avoidance, consideration of medical comorbidities. All of this is in search of one's personal equation for the development and maintenance of functional neurologic symptoms. Other frequent components include an examination of triggers and warning signs. And as patients become more aware of warning signs, right, the instruction and relaxation techniques and distraction techniques can be used at the time of those warning signs, hopefully to prevent or lower the severity of FND flares. I'm not doing a deep dive into the treatment of functional seizures. I will say that education, engagement, and skills-based psychotherapy are the most well-studied components of the treatment in this population. But you also want to think about other biopsychosocial considerations, as I've outlined elsewhere. For those of you interested in a deeper dive into the outpatient literature, here are several articles from our outpatient FND clinic. For those of you interested in a deeper dive into the intensive short-term treatment literature, both outpatient and inpatient, some potentially useful articles here. Several books have been published by field leaders. You might consider a relevant educational resource as well. And then thank you for the opportunity to visit with you all. If you have follow-up questions, please feel free to email me. I'd be happy to answer them if they're not answered in the live Q&A. Thank you very much.